Morning. Yesterday we talked about a lot of detailed stuff about the acetabulum and the pelvis, but in reality, the next set of talks is probably more relevant. Everybody in the room's taking care of the gray tsunami, the influx of hip fractures, and as we'll talk about this afternoon, the geriatric fractures. The pendulum with regards to the treatment of femoral neck fractures in older patients is definitely swinging more away from the internal fixation and towards the arthroplasty. And there's some good data for that to happen. Commonly in orthopedic surgery, things change and there's no really good reason for why things change. But I think in this case, and I'm going to try to show you, there's a good reason for us to be leaning more towards arthroplasty in these patients and less towards internal fixation. So this gray tsunami, as it's been referred to, an estimated 300,000 hip fractures in this country annually. Boy, some weekends it certainly feels like more than that. On a typical Thursday night, there'll be 4 hip fractures that come in this small community hospital where I work. They account for about 30% of hospitalizations, so it's a big number. And the World Health Organization estimates that by 2050, there'll be 6 million hip fractures a year, and that's an incredible number. We're living longer, we're staying active, and unfortunately, osteoporosis is rampant as well. So there's a bimodal distribution, as we're all familiar with. What I'm trying to focus on in the next 10 minutes is the treatment of hip fractures in the older individuals. These are usually lower energy fractures, occur after the age of 50 or so. More commonly in an increased incidence in women, Caucasians, smokers, those with lower bone mineral density and lower BMI, and those of us who drink excessive coffee and, like Kyle, excessive alcohol. The other side of the spectrum, of course, is the high energy individual who makes bad choices and sustains a femoral neck fracture from high energy trauma. A little anatomy. The physis closes about the age of 16. Of course, this varies amongst genders. The neck shaft angle, which is important for us to realize, about 130 degrees plus or minus 7 degrees. Anteversion, this might be a little bit of an underestimate, but 10 plus or minus 7 degrees. So this is important. You got to know what's normal before you know what's abnormal on your fracture images. And there's general alignment between the femoral neck and the center of the femoral head on both the AP and lateral images. So that's important too, as you'll see. The blood supply to the head, and this really influences, should influence how we're treating these patients, and it influences how they turn out, particularly if we choose to fix them. The terminal branch of the medial femoral circumflex artery is that lateral epiphyseal artery, and that's responsible for providing the blood supply up the retinaculum and into the femoral head. And if this is disrupted at the time of the fracture, then these patients seem to benefit more from a replacement as opposed to internal fixation. And there's some evidence now radiographically where we can determine whether that blood supply has been disrupted or not. There's also some mention in the past that greater fracture displacement, greater disruption of these retinacular vessels. And there's been, 20 years ago, some talk about a tamponade effect. As the capsule fills up with blood, even if these blood vessels aren't disrupted, it prevents the blood from flowing into the femoral head and will lead to avascular necrosis in the future. So the diagnosis, this is not rocket science. We generally use plain films, even though I've been to Röntgen's lab in Visberg, Germany. The first x-rays were taken in 1896. That's mind-boggling that we're still using this technology, but it's convenient. We have it in the operating room. It's ubiquitous. It's everywhere in every hospital. And for femoral neck fractures, it's usually pretty good, but you got to know what's normal, and you got to get good images as well. CT scans are also helpful if you're having a difficult time making the diagnosis, or in this case, in this young healthy individual, the CT scan is very nice at showing us the comminution of that femoral neck and what we're up against. MRI, I was with Pete Rizzo at Special Surgery in the early 90s when he started investigating the use of an MRI to diagnose occult femoral neck fractures. These are usually elderly patients. Nobody kind of witnessed their fall, but they end up with generalized pain and maybe some hip pain. They're unable to bear weight. Your physical exam's kind of equivocal, and the x-rays and the CT scan aren't helpful. So in some cases, and it's not a great number of them, MRI can be very helpful in making the diagnosis and helping us treat these patients effectively. In the past, we had to wait a couple of days and get a bone scan and see if they reacted to the bone scan. But MRI, if you can't make the diagnosis any other way, get them an MRI. Unlike, like the use of plain films for over the last 128 years, we're still pretty much using Gardner's classification for femoral neck fractures, which was proposed in 1961 based on a single AP x-ray. I mean, one of the hand surgeons, we're getting old. One of the hand surgeons yesterday said, no, I would never let my resident just bring me a single x-ray, but here we are using Gardner's classification over the last 63 years or so. That being said, it was pretty simple. It's still pretty simple. 1s are valgus impacted, 2 are complete non-displaced, 3 and 4s are partial and fully displaced. And generally, we consider 3 and 4s unstable. Those patients get a hemi in the right, clinical setting, and 1 and 2s we tend to fix, or at least I tended to fix. Powell's classification has been used for the younger patients, has more to do with the fracture orientation, the stability to fracture, and gives you an idea of how difficult it is going to be to get that fracture to heal after stabilization. Our treatment goals in older patients to get them out of bed. I just mentioned my mother passed away in November at the age of 96 and a half, and we made sure she got out of bed every day because one day in bed for some of these patients is almost a death sentence. Then, not only from the bed sores, the swelling, the changes in their cognition. So our goals should be in a medically optimized patient to get them in the hospital, get them fixed, and get them up. And don't let them talk you out of it. We had to call the police on this old lady here just to get her up out of bed, but I don't know what they're doing there. And in the past, we've tried to minimize our operation, minimize our anesthesia time, our blood loss, and muscle dissection, and reduce the risk of reoperation, of course. But that's why I think we went to the use of cannulated screws for those Garden 1 and 2s. And it doesn't always work out. So if you minimize your time in the operating room the first time, and then you got to go back because of a non-union or a collapse of the head or breaking of the screws, then you really haven't done yourself a favor. We've spent a lot of time in the past talking about the orientation of these cannulated screws, the use of a compression hip screw with a derotation screw, and now on the market a femoral neck system. You can see here, you can see here for those truly Garden 1 and maybe some of the Garden 2 fractures. We have to take into consideration patient factors, of course. This is someone I was presented with the other day, a very arthritic hip and a subtroch fracture. I know it's not a femoral neck fracture, but you have to look at the whole package. We do sometimes get patients with femoral neck fractures and horribly arthritic hips. That decision, I think, is pretty easy. If you fix them, they're still going to have a pretty arthritic hip. So the decision-making variables, the fracture factors, is starting to our better understanding of the fracture factors is unraveling this internal fixation for Garden 1 and Garden 2 type of fractures. And there's a lot of data, and you can see starting back in 2009, a lot of talk about this posterior tilt angle, the PTA, and when it approaches or exceeds 20 degrees, those patients are at higher risk of needing a reoperation if you just fixed a fracture. So that's why I think the pendulum is starting to swing more towards the more invasive procedure, but one that'll get them on their feet faster and hopefully avoid the need for a reoperation. These articles are great if you're not convinced. This is just 2 of the graphs. This one is 113 patients. It was published again in 2009. And what it shows was those patients with a posterior tilt angle of less than 9 degrees. There were 40 patients. Their reoperation rate was about 15%, same if it was between 10 and 19 degrees. But look at that third group. Look at that third group. They only had about 40 patients, but the reoperation rate was 55% or so. And then they were able to do a hazard graph here that shows, again, as that posterior tibial, tilt angle increases, your increased likelihood for reoperation. So we're not really doing these patients a favor by doing a small little operation, putting 3 screws in a half hour in the operating room, if we have to come back at 3 months and do an arthroplasty. What arthroplasty? Well, I think Andy's going to discuss that shortly. Which arthroplasty? So in summary, femoral neck fractures in less than 60 years old, we try to save those hips and avoid the use of arthroplasty. In the older patients, in the past, we've used internal fixation, particularly in those Garden 1 and 2. I think now the pendulum, and we should strongly consider the use of arthroplasty for these patients as well. You have to take into consideration all these factors when making this decision. And so again, I think the trend is now more towards arthroplasty for these patients, even with a supposed Garden 1 and Garden 2, as opposed to fixing them. Thank you.